Microbiologic data is critical to establishing a diagnosis and targeting treatment. Yet interpreting positive microbiologic cultures is not always straightforward. Human epithelial surfaces, like skin and mucous membranes, are covered with commensal microorganisms. In fact, current estimates suggest that the number of bacterial cells in and on our bodies are equal to or exceeds the number of human cells. As we discussed in the module Principles of Antimicrobial Prescribing, part of reviewing microbiologic data is asking yourself, does the microbiologic data make sense? A positive microbiologic culture could represent colonization, contamination, or true disease. Differentiating between colonization, contamination, and a clinically relevant culture is one way to incorporate antimicrobial stewardship into your practice and is critical to providing the best care to our patients. The correct interpretation of a positive microbiologic culture ensures that we as clinicians prescribe the optimal antimicrobial treatment to the patients who really need it, but avoid giving antibiotics when they aren't necessary. The unnecessary use of antimicrobials to treat colonization or contamination is common and can lead to considerable harm. People may experience adverse effects of medicines that they simply do not need, and microbes are exposed unnecessarily to antimicrobials, which can drive antimicrobial resistance. Differentiating between colonization, contamination, and a clinically relevant culture result requires a careful assessment of the clinical situation, an understanding of how the specimen was obtained, and an appreciation of what microbes would naturally be expected to be found in or on particular body sites. Let's review broad definitions of each of these scenarios. First, colonization. We know that commensal bacteria colonize body sites such as the lower respiratory tract, or sputum, nasal sinuses, and superficial wounds without causing actual infection. Second, contamination. This occurs when exogenous microorganisms are unintentionally introduced into a clinical specimen during specimen collection or handling in the laboratory. And finally, infection. This is when positive culture results represent true infection rather than colonization or contamination. Let's consider a case. You are examining a 65-year-old female who presented to the emergency department with fever and dysuria and was diagnosed with a urinary tract infection. She was admitted for monitoring of her atrial fibrillation with rapid ventricular response. 2 sets of admission blood cultures were drawn from 2 separate venipuncture sites and are growing Staphylococcus epidermidis in 1 of 4 bottles. This is a common clinical scenario. Staphylococcus or Staph epidermidis and other coagulase-negative staphylococci are common skin commensals and are also frequent blood culture contaminants. Among patients with blood cultures positive for coagulase-negative staphylococcus, the majority will be contaminants. Bacteria from the skin of the patient or the healthcare provider contaminates the needle or enters the bottle during the process of obtaining blood for culture. When this happens, the coagulase-negative staphylococci identified in the culture are not circulating in the patient's blood, but they've been detected because of lapses in sterile technique. However, coagulase-negative staphylococci can cause disease in the right clinical situation. They are the second most common cause of prosthetic valve endocarditis after Staph aureus and can cause infections related to other prosthetic materials, including vascular grafts and cardiac devices. Rarely, coagulase-negative staphylococci can also cause native valve endocarditis. Staphylococcus lugdunensis is a unique coagulase-negative staph species that behaves like Staph aureus and can cause the same types of infections. So, a positive culture growing a coagulase negative staph species cannot be summarily dismissed as a contaminant. As we reviewed in the bloodstream infection module, appropriate collection technique is critical to obtaining meaningful microbiologic data. This is especially important for the collection of blood for culture. Other important factors related to specimen collection include the following: blood volume. Obtaining an adequate blood volume is critical to the yield of blood cultures or the ability to recover bacteria from the blood of a patient with a bloodstream infection. Studies show that the yield of blood cultures in adults increases when more volume is obtained. Please refer to the bloodstream infection module for details and for the recommended blood volumes that can be obtained safely for adults and children with a suspected bloodstream infection. Separate venipuncture sites. Most guidelines recommend obtaining blood for culture from at least 2 separate venipuncture sites if possible. This can assist in the evaluation of possible contamination of blood cultures. If blood culture bottles are positive from separate venipuncture sites, this increases the probability that the positive blood cultures represent true infection in the right clinical scenario. If for some reason it is not possible to obtain blood from 2 separate venipuncture sites, blood from a single site can be used, but this information must be recorded to allow for appropriate interpretation of blood culture results. And finally, timing. Blood for culture should be obtained prior to the initiation of antibiotics. However, antibiotics should not be delayed for patients with sepsis. When reviewing microbiologic data, clinicians can use the following to help distinguish a meaningful blood culture result from one that represents contamination. First, the genus and species of the organism can help. Some species, like E. coli, are very uncommon contaminants, while skin flora, such as coagulase-negative staphylococci, are more common contaminants of blood cultures. Although a common member of the skin flora, a positive blood culture for Staphylococcus aureus should not routinely be considered a contaminant given this organism's propensity to cause severe infection. The number of sets and of individual bottles that are positive can also help. The more blood culture bottles from separate sites that are positive, the more likely it is that they represent true bacteremia. For example, if all bottles from 2 sets of blood cultures, meaning 4 out of 4 bottles are positive, it is more likely to represent infection than if just 1 bottle out of 4 is positive. And finally, the number of species isolated can also help with interpretation. If a single species is isolated from multiple blood culture bottles, it is more likely to represent true bacteremia. In contrast, mixed cultures of more than one species are more likely to reflect contamination. Let's return to our case. So, does the microbiologic data make sense? In this case, only 1 out of 4 blood culture bottles from 2 separate venipuncture sites are positive for Staph epidermidis, which raises the possibility that this result represents contamination instead of true infection. You review this patient's past medical history, and she has no specific risk factors that would predispose her to an intravascular infection. Specifically, she has no indwelling prosthetic material, like a pacemaker or a prosthetic heart valve, and she has no indwelling intravascular access, like a central line. Her clinical symptoms of dysuria and fever are also adequately explained by another infection. She was diagnosed with a urinary tract infection based upon symptoms and a positive urine culture for E. coli. You determined that this positive blood culture for Staph epidermidis is most likely a contaminant and that this patient does not require antibiotics directed at this pathogen. This case also stresses the importance of obtaining blood culture sets from separate sites. If only 1 blood culture set was obtained and 1 of 2 blood culture bottles were positive for coagulase-negative staph, it would be more challenging to determine that this result represented a contaminant than it was for you when 1 out of 4 blood cultures was only positive. Let's consider another case. A 62-year-old man with long-standing, poorly controlled type 2 diabetes mellitus presented with a painless ulcer of his right foot that had been present for a month. He had previously had a diabetic foot ulcer of the left foot that had been successfully treated. On examination, he was afebrile. His right foot was swollen, and there was a 4-centimeter plantar ulcer over the first metatarsal head with purulent discharge and minimal surrounding erythema. The foot was not warmer to touch than the left foot. The wound could be probed to bone. The foot did not have sensation to light touch or pain, presumably due to peripheral neuropathy. Peripheral pulses were intact. The X-ray revealed evidence suggestive of osteomyelitis of the first metatarsal head. A specimen for gram staining culture was obtained by swabbing the foot ulcer, and empiric therapy was initiated with ceftriaxone. Examination of the gram stain revealed a moderate number of polymorphonuclear leukocytes and mixed bacterial morphologies, including gram-positive and negative cocci and gram-negative bacilli. Culture of the specimen subsequently yielded Staphylococcus aureus, several anaerobic bacteria, and Pseudomonas aeruginosa. Based on the results, treatment was changed to meropenem and tobramycin. The tobramycin was soon discontinued, however, because of an abrupt increase in serum creatinine. This is another common clinical scenario. It is estimated that the lifetime risk of development of a foot ulcer in diabetic individuals approaches 25%, and these frequently become infected. Such infections are commonly associated with osteomyelitis and may lead to amputation. Although bacteria are likely to be present, not all diabetic foot ulcers are truly infected. Usually, we expect infection to be associated with pain, warmth, redness, and swelling. If these features are present, then infection should be suspected. In some people with diabetes, the clinical assessment can be more complex. There may be minimal erythema and warmth because of autonomic insufficiency and a reduced inflammatory response. Patients may not report pain because they lack sensation due to peripheral neuropathy. In this case, X-ray changes are worrisome, but could be nonspecific in others, and must be differentiated from diabetic osteopathy. Being able to reach bone by insertion of a blunt probe into a diabetic foot ulcer is, however, important because it is highly suggestive of the presence of osteomyelitis. Because of a strong likelihood of infection, appropriate specimens for cultures must be obtained and should be done prior to the initiation of antibiotics. However, cultures obtained by superficial swabbing of the open wound are misleading. They are highly likely to yield mixed bacteria as the result of exposure of the ulcer to the external world, with consequent inevitable bacterial colonization. As an example, recovery of Pseudomonas aeruginosa is often associated with patients having soaked their feet in tap water. Obtaining such cultures can lead to therapy that then leads to adverse effects, as occurred in the case described here. Let's return to that case. An MRI examination of the foot confirmed the presence of osteomyelitis of the metatarsal head and also revealed a plantar abscess. On day 3, by which time the tobramycin had been discontinued because of concerns for acute kidney injury, the patient was taken to the operating room. There, he underwent drainage, debridement, and resection of the metatarsal head. All deep specimens obtained yielded only methicillin-susceptible Staphylococcus aureus on culture. Antibiotic therapy was changed to cefazolin, a first-generation cephalosporin, with return of serum creatinine to baseline and subsequent wound healing. This case illustrates an adverse event resulting from inappropriate antibiotic treatment that was selected based on misinterpretation of a culture result representing wound colonization rather than true infection. In addition, it demonstrates that the results of a superficial swab can be quite different from that of a deep, sterile specimen. Skin ulcers should be expected to be colonized with bacteria. Not all of these bacteria will necessarily be pathogens. If the ulcer does not have clinical features of infection, then antibiotic treatment may not be necessary at all. If, however, osteomyelitis is clinically suspected, it is preferable to obtain deep samples of tissue or bone to identify the causative pathogen and allow for targeted antibiotic therapy. Unnecessarily broad-spectrum antibiotics can lead to patient harm. As we've discussed in previous modules, the minimal inhibitory concentration, or MIC, is defined as the lowest drug that prevents in vitro growth of a bacterial isolate in culture. Laboratory governing bodies like Clinical and Laboratory Standards Institute, or CLSI in the U.S., and the European Committee on Antimicrobial Susceptibility Testing, or EUCAST, publish clinical breakpoints that are used to interpret MIC values generated by frontline clinical laboratories. An isolate with an MIC value above the clinical breakpoint would be interpreted as resistant, while an isolate with an MIC below a clinical breakpoint would be considered susceptible to a particular drug. For some drugs, CLSI may recommend interpreting some MICs as intermediate or susceptible dose-dependent, while EUCAST may recommend a slightly different interpretation, such as susceptible increased exposure. In this case, the MICs indicate, as expected, that the isolate is susceptible to oxacillin and is thus susceptible to early-generation cephalosporins, including cefazolin, at readily obtainable serum concentrations. The MEK-A gene was also not detected, confirming that this is a methicillin-susceptible Staphylococcus aureus, or MSSA, isolate. Recall that this gene encodes for penicillin-binding protein 2A, which confers methicillin resistance in most methicillin-resistant Staphylococcus aureus isolates. This is another representation of susceptibility testing results for a methicillin-susceptible Staph aureus isolate using the disc diffusion method. Again, as expected, the isolate is susceptible to early-generation cephalosporins. In this method, an agar plate is streaked with the suspension of the organism matched to a standard density, and paper discs impregnated with different antibiotics are placed onto the agar surface. This method relies on the diffusion of the antimicrobial agent into the medium, thereby forming a gradient of antibiotic around the disc. The antibiotic concentration is highest around the disc and then gradually decreases as the distance from the disc increases. The organism grows where the activity of the antimicrobial agent is overcome. The area around the antimicrobial disc in which the organism's growth is inhibited is called the inhibition zone. The diameter of the inhibition zone is measured and used to determine the susceptibility of an organism to the agent in question. For example, in the picture here, the Staph aureus strain has an inhibition zone diameter of 26 millimeters with cefoxitin 30 microgram disc. This is interpreted as susceptible using both CLSI and EUCAST guidelines. This enables the categorization of the Staph aureus strain as methicillin susceptible, as cefoxitin is the preferred agent to test for the determination of methicillin susceptibility in Staph aureus using this technique. In summary, interpreting positive microbiologic cultures can be challenging. Clinicians must determine if a positive culture represents colonization, contamination, or true disease. Only true disease should be targeted with antimicrobial therapy.